the outset, I wish to thank the organizers, and specifically Ashwini and Jairam, for having me here in this fantastic course. And many congratulations to all the ophthalmologists of Kerala on your 52nd annual conference. I think the previous speakers very elegantly covered almost all aspects of management and all how the TFOS Dues 3 has changed from the TFOS due to deliberations or elaborations of how you will have to approach dry eye. So now I'm going to talk to you on what's probably new or what can we actually adopt in the way we are managing dry eye disease so that it brings about a better refractive outcome or a better clinical outcome to our patients. I do not have any financial interest in the mention of any of the products during the course of this talk. So when you look at dry eye treatments, what is the alma mater of devices we have? We look at local agents which can probably help in increased your production. And what we have new in that field or in that aspect is nasal sprays here. But it's still yet to be available in India. You could probably get them from abroad online, but these are yet not available in India for management. So that's something which is lacking, but that is to start with what's new and available in nasal spray therapies. When you move to punctal plugs and how you can adopt punctal plugs in your management, I think Jairam has very nicely elaborated those aspects here. But a few key points you will need to understand is when you will have to use the punctal plug, what type of punctal plug will you need to use? You want to use the temporary or the permanent ones here, and what investigations you need to do on your patients before you would consider punctal plugs. So these aspects are critical when you are managing dry eye disease patients. It's not a one size fits all kind of a management when you are managing dry eye treatment. That is something you need to understand. And in those patients where you are having an aqueous deficiency dry eye disease, where you want to decrease the evaporative loss of the already existing lesser pool of tears, is where you're going to apply your punctal plugs here. And if there is an inflammation component already present on the ocular surface, then you will probably need to treat the inflammatory component before you're going to plug the outlets here. Because if you're going to plug the outlets on an inflamed ocular surface, that's going to increase the surface inflammation and the discomfort quotient and the epithelial damage here. So this is critical in understanding what is the timing and what is the right subset of patients where you will be successful when you're using punctal plugs here. If you're dizzy and you do not know whether it's really going to work, that's when you're probably going to use the approach of temporary punctal plugs. And then when you find it is suitable for that particular patient, you will probably move on to use permanent punctal plugs for these patients. So these are some sort of management guidelines or some sort of understanding of the basic pathology of the patient you're treating, which is going to help you in the success of the outcome when you're managing dry eye disease patients here. And now moving on to the next, we have the anti-inflammatory medications. I think there's a lot of new entrants in this particular field here. And what we need to understand is which anti-inflammatory agent is probably going to help you and when you need to apply them for the success in management of your patients. And of course, the specialized devices which we have in dry eye disease management. So Tariva is from Oyster Point is a varenicline, which is an FDA approved one, but it's still not available in India. You have the variety of punctal plugs which already elaborated to you. We'll now move on to anti-inflammatory agents which you need to have. I think a lot of which has already been said where you have lifitegrast, which is the new entrant. We do have several commercial formulations which have now come into the Indian market here. And this is an LFA1 antagonist, so a lymphocyte function associated antagonist here, where it blocks the adhesion to the ICAM1, which all induce inflammation and inflammatory mediators release here. And most of the commercial available agents, the pharmaceutical companies claim that it gets into action as early as 2 weeks vis-a-vis compared to the earlier earlier anti-inflammatory molecule, which was cyclosporin, which has been approved. So lifitegrast is the second anti-inflammatory molecule, which is FDA approved for treating ocular surface inflammation in cases of dry eye disease here. But I think I personally do not use a lot of lifitegrast, and my discussions with those who are using lifitegrast is not that it is very proactive. It's probably similar to how cyclosporin is functioning here. So we still do not have a molecule which is going to be giving you an effective, immediate anti-inflammatory action, just as you would need, just as you get with steroids. So I think steroids still remain the first line of management when you want to control surface inflammation, and the potency of the surface steroids you want to use, whether you want to use a high potency surface steroid, a medium potency surface steroid, or a low potency surface steroid, will be dictated by the severity of the ocular surface inflammation which you are looking at in your patients here. So lifitegrast, the mechanism of action, I think already was well described by Benny here. So these are more of textbook, and if you have postgraduations and fellows here, I would urge you to go back and look at the mechanism of actions here. The dosages available is 5%, which is 50 milligram per ml is what is available. It's claimed to work at 2 weeks, but I think you will need a longer installation before before these drugs are going to come into action here. So what we have moved on from anti-inflammatory is to the targeted approach to management of dry eye disease, or how you use medications for targeted approach. I think the biological tear replacements in terms of using autologous serum, in use of platelet-rich plasma. So these are all medications which have been available, but the only downside to it is you do not have them commercially available, and you will have to resort to an in-house pharmacy if you have one, or you have to resort to centers who can make this from the patient's own blood here. So that's the downside, but they are rich in a variety or multiple growth factors, which helps in healing of the ocular surface where there is epithelial damage here. So that was something which has existed for over 2 decades. But how have we moved out, or how have we climbed further in the targeted approach to dry eye therapy, is where we are looking to particular agents here which will act on those molecular pathologies which are causing the inflammations here. So what we have is a low dose heparin which acts on the nets of the ocular surface. So what's our nets here? These are extracellular nuclear traps here. So when ocular surface inflammation occurs, there is a lot of extracellular release of DNA material here, which is probably responsible for the refractory ocular surface inflammation, which does not respond to your steroid therapy in certain subset of dry eye disease patients. So identifying these nets and identifying particular medications which will act against these nets is also going to increase your outcome, especially in those group of refractory patients where you're going to need these medications here. So this is a fantastic picture, and I'm talking to you more about it because my topic is about visionary research and what we have found is really going to help, and what is probably accessible to in our clinical practices here. So this is particularly a new discovery where we are looking at the presence of ACPs, or anti-citrullinated protein antibodies, which are present in the tears, and this led to the concept of use of topical immunoglobulins, IVIG drops. We can use the intravenous immunoglobulins, formulate them to ocular surface immunoglobulin therapies, and these will particularly act on the surface nets to decrease the surface inflammation and bring about better response to the treatment which you are having in these patients. Ocular GVHD, severe SJS patients, severe Sjogren syndrome patients are those subsets of dry eye disease patients which do not respond to the conventional topical managements, and these are the subset of patients where you will need to resort to adoption of such targeted therapies, and they do work well. For those of you who are interested, I would refer to our latest recent publication here, which will give you a particular insight on the success and how you would go about managing patients using ocular surface immunoglobulin IgG therapies for these subset of severe dry eye disease patients. Yeah. Again, what is new and probably been, this is a revolutionary paper which came out about 4 years ago here, round about the period of COVID here, when NETs was identified as the reason for refractory ocular surface inflammation. And then using a particular medication such as the A topical DNA is 0.02% here. So this is recombinant DNase. This has been available and has been used for patients with cystic fibrosis, particularly in pediatric pulmonary fibrosis patients here. Availability is a particular difficulty here, but recombinant DNase works fantastically well when you are using it on patients with severe refractory dry eye disease well. So we've just concluded our research on the use of adjunct therapy with topical recombinant DNase, and this really helps in resorting to the patient, resorting to an increased comfort levels and decreasing the clinical signs and symptoms of these patients. But again, understand that all these targeted therapies work optimally only once you have probably reduced the severity level of the surface inflammation using topical steroid therapies. You optimize the surfaces and then you resort to adjunct therapy with these targeted molecules, and they will help you in better outcomes of these patients. The devices, I think you have several devices starting from thermal devices, intense pulse light devices, QMR electromagnetic field devices, which all help you to give you a better to help you in the ocular surface problems here. But then here you remember, this is where patients have lid disease, chronic lid disease, which is probably contributing here. So it's not going to be applicable for all subset, but you will have to know what is the source and what is the diagnosis which is causing dry eye disease and where you need to apply these patients here. So Procera, again, these are devices or amniotic membranes which are commercially available, which can be applied onto the ocular surface. But what I do find effectively, which we can adopt to our practice, is how we use scleral contact lenses for patients. You need not really always use pros contact lenses, which are very expensive. You could effectively use with optimal fitting. So you need a really devoted team here of your corneal physician and your optometrist to work in close tandem. The ocular surface needs to be optimized in terms of controlling the ocular surface inflammation, and then move on to adopt to the wearing of these scleral contact lenses, which can be both therapeutic and refractive for the patients here. This is one of my patients of Stephen Johnson's who presented very severe dry eye disease, refractory to the traditional treatments, and when we slowly optimized his surface and moved him on to scleral contact lens. He's now on scleral contact lens for almost 4 or 5 years here. And he's a computer professional and is very comfortable using his surfaces, and it's amazing to see how these eyes do turn on from being inflamed eyes to white eyes such as this. But then you do need a continued team effort and continued close follow-up for effective management of these patients here. So that's a few of our clinical pictures of those patients who are on scleral contact lens wear as therapeutic measures for contact lens for ocular surface disease here. I will stop here and thank you for your patient listening.